I'll share my perspective on what really makes it tick. COVID or non-COVID, these things, we know that this is not the last pandemic which we are going to witness in our lifetime, thanks to it's connected world. The world is, and when we look at the history of Spanish flu, it just came to the Indian subcontinent through ships, the sailors coming back after the world wars. Right now, if you just look at right from 2020, you can really map out the emergence of COVID from the international airports spread across the country. So if you look at the state of Kerala, one big hotspot right now, 4 international airports, Delhi, NCR, busy airport, Mumbai, same situation, Kolkata. So that's really the pattern what we are seeing around the world. So what I'm planning to do is that step back away from COVID, because that's all of us know that what's happening in the background. Maybe we can address that in the Q&A session. But I would really first talk about, from a healthcare point of view, this concept of chaos, AAA, which I think is fundamental for anyone in the healthcare space. Economics is very important to figure out where the funding is coming from and how sustainable it is, despite whatever's happening in the macro environmental region. Of course, demand supply gap, constant demand supply gap, changing demographics, the economic pie into that. Demographic itself, mobility pattern around the world is changing. Financing model, but digital is the new frontier, where there is a big push and a lot of capital is sucked into digital. And of course, at the end, we have a summary of the resilience model. So first, looking at chaos. So I have this this theory that we can sit and debate for days together about COVID-19, the origin of the virus. We all speculate that this has definitely come out from the Wuhan Institute of Virology, but we do not know whether it is just an accidental lab leak or is it a bioengineered virus. Nobody knows that, because WHO has not given its conclusive statements. And so the jury is still out there. How did this virus originate? But if you look at from an Indian context point of view, thankfully that despite this, the tragic absolute numbers of mortality and morbidity across India, what we have seen and around the world, imagine that Ebola was equally airborne as COVID-19. Just imagine that. Those of you who are fans of Netflix and you see these iconic Korean cinema on Netflix, you've seen those zombie type of, the zombie movies, mostly popularized by the Korean cinema. I always used to wonder that what if it that you have an Ebola kind, which is really the case fatality ratio so high in comparison to COVID-19. So in that perspective, we are relatively better off. I'm just putting a spin to it. But the fact of the matter is that in India, we have these hotspots of Nipah, starting off from the famous episode of one of the first incidences in the Siliguri. In fact, the town of Siliguri was where there was a Nipah outspot many years back, where almost a large segment of healthcare workers in Siliguri was wiped out because of Nipah. And it took some time for the healthcare officials in the government of West Bengal to realize what really was happening in Siliguri. To the recent memory of what happened in Kerala, North Kerala, especially in the city of Kozhikode, there was this Nipah outbreak, and how successfully the public health system in Kerala responded to manage that and localize that. And it didn't really become a big issue. So what the slide is trying to say is that as administrators or people, I would say welcome to the dark side, because healthcare management, there always used to be this paradigm or a communication barrier between pure clinicians and those of us unfortunate enough to be in management. So it's like coming to the dark side. So welcome all of you to the dark side. The reality is that things are quite chaotic out there because of climate change, environmental reasons. I had this experience of, when I came back from Egypt to manage the hospital, the first hospital which I built in Kochi of Aster MedCity. That was the biggest single investment in 2013 at that point of time, roughly around 700 crore rupees in one project. It's an iconic project. So that hospital is located on the banks of the longest river of Kerala, Periyar. And I remember coming straight, from the airport in Egypt. I landed from Cairo to Kochi, and then I had this first project around. I went to the construction site one of my first questions I asked the project team is, could you please show me the 100-year flood data of the river Periyar? So they laughed at me. I could see the sheer skepticism and cynicism of the team. The team that time, the PMCM, Project Management Construction Management Team was Synergy, which incidentally the same team had built Medanta in Gurgaon. So that is the reason why Aster DM had brought the same construction project management team to, because the scale of MedCity was similar, or if not bigger than Medanta. But they just ignored these kind of comments and concerns which I had raised. 2018, while I was still I was still effectively in charge as the CEO of that hospital, we had the famous monsoon fury cloudburst across the Western Ghats, and the river actually flooded, and water came in. The hospital had to we had to evacuate more than 300 odd patients in an 8-hour time period in one day. Take them across to other hospitals in the city of Kochi, and shut down the hospital for about 10 days before we could get back. So I'm just giving you examples of chaos in the environment. Just previous to that, if you go back to 2011, I was the CEO of the largest hospital in Egypt. So, I used to proudly say that Egypt, and Cairo specifically, is a city which never sleeps. It's beautiful, beautiful city. It never sleeps because people are just out there wee hours of the daytime, and it is such a beautiful city. And I remember 26th of January, 2011, the few of us from the Indian community, we went to the Indian embassy to hoist the Indian flag. And there were some security issues we heard in the city of Alexandria, and we were talking to each other. Then we said, well, Hosni Mubarak is the president, and he's like Ramses II, nothing's going to happen. But the Arab Spring took off, the whole country went into a meltdown. And of course, I had to run my hospital. And that is the time when first time I experienced multiple gunshots, patients with multiple gunshots coming from Tahrir Square, coming to my hospital, and, total chaos in the environment. So this is another example of chaos, man-made chaos. All of them are man-made, in my opinion, whether it's to do with climate change, whether it's to do with viral pandemics or epidemics, and also to do with revolutions and strife. So this is a scenario in which, at the macro level, we are running hospitals. Fourth, one last example as food for thought is the rules of the game when it's changed overnight. When you put an investment for a hospital, you have certain ground rules about, especially private investment I'm talking about. You have certain business model assumptions of payback period, return on capital employed, return on investment. You have some parameters in mind. But what happens when the regulatory authorities, whether at the central government, federal government level, or the state government, overnight changes the rules of the market, so to speak, whether it's to do with your price, essential, like what we have in India, NPPA, the price capping, which has been enforced, or consumables, or let's say because of COVID-related price caps on services. What do you do with your business model? So that also puts the entire steady state affairs into chaos. So that's basically how vulnerable and how exposed all of us are in the management of healthcare space. Now, just going back to certain basic principles. So AAA is something which all of us in healthcare need to understand, and it's throughout the world. Accessibility, affordability, and assurance. Whether you're in the public sector or private sector, these are the cardinal mantras of healthcare, and everything is focused on the consumer, which is, a citizen of the world, whichever country you belong to. Just to give you some parallels between India and the Philippines, where I'm based right now, you have a landmark. I used to always frequently think about when is that the politicians in India are going to put healthcare as part of the election manifestos, and really invest political capital in healthcare as a force multiplier for economic empowerment, for creating equity in society, and also as a vote bank technique to fetch more votes. I used to always wonder, and this thought was mainly looking at the democratic practices and the election debates in the United States and also in the United Kingdom. In the United States, we always, before, if you remember Bill Clinton, when he was the president of America, Hillary, his wife, was the chairperson of the task force for reformation of the American healthcare system. And that went into huge opposition by the Republicans in the Senate and never took off. Then it required, much down the line, it required a president of Obama's caliber to put up Obamacare Act, which is basically to ensure that the 40 million Americans who are outside the safety net, you can bring them back into some kind of a safety net program. It is still, what Trump did. Trump was still trying to nibble away on the safety, on the basic social safeguards which Obamacare has already put into place. In India, Prime Minister Modi, in the first term of NDA, had really taken multiple initiatives in the healthcare space. But I'm really focusing on access, affordability, and assurance. So the program which I'm talking about is PMJ, which I'm going to touch a bit more in detail later. But that was catering and focused to 500 million citizens who are below the poverty line. So that's India's case study. In the Philippines, the current president is due for re-election in May this year, in 2022. And because of historical reasons in this country, the presidential term is just 5 years, after which the sitting incumbent president cannot have a second term. So they have to go for elections. But one of the priorities of this president, who is perceived from a global political left of center, right of center point of view to be more right of center. But key political decision he has taken is to, by law, pass what is called the UHC Act, Universal Healthcare Act. The Universal Healthcare Act specifies that every Filipino, this is a country of 110 million people, every Filipino should have access to care in the whether it's public or private, it does not matter, should have access to care at the point of need. So this is something quite remarkable. And of course, there's a paying mechanism to support that. So the first apex of this pyramid of accessibility is already addressed in the case of Philippines. Affordability, and now I talked about Ayushman Bharat there, and there is still huge amount of regulatory pressure, which is in India's case, it's mostly to do with state governments, because healthcare is in the concurrent list in our constitution. Whereas in the Philippines, what they've done is, by law, 10% of all hospital beds, whether you're especially in the private sector, it's mandated what is called a zero billing concept. So if a Filipino comes to, let's say, of course, this is only for general wards. If they come from an access point of view, you cannot charge anything beyond that. It's more or less packaged, determined by regulation. And if there is any excess billing, you have to absorb as a hospital. That is called the zero bill balance concept, which is at 10% reserve. So that's to do with affordability. Assurance is what the Quality Council of India started off more than a decade back, our national accreditation program with NABH in India. Philippines has got an equal system of hospital accreditation. And something which some of us are involved is that Quality Council of India, NABH, and the Philippine authorities are working on an active collaboration. In fact, NABH Philippines is one of the countries in Southeast Asia where NABH is recognized, and there is transfer of know-how from India to Philippines to create a similar kind of a quality accreditation system. So this is the 3 A's of healthcare. A bit more deeper dive is when you look at payers, you have all kinds of models out there, whether it's a tax-based womb-to-tomb concept started off after the Labour government in the Second World War in the United Kingdom. You have the social health insurance model, which is in Germany. Of course, my favorite is Singapore. Singapore being easily manageable, being a tiny dot out there. But it's the Singapore model is a bit more democratic in the sense that it's a bit like our provident fund system. All of us who are in the formal employee category, the employee contributes something into the provident fund, so does the employer. But in the Singapore context, this is basically like a health insurance kitty. And after a certain annuity period of lock-in, you are also allowed to take loans for specified areas from this kitty which you're putting up. And it is a more equitable context because no Singaporean is denied quality and access of quality of care because of a socioeconomic status. And there are different insurance products available in Singapore catering to your socioeconomic background, so that safety net is there for all of them. So that's why I felt that Singapore is an apt model. In the case of Philippines, PhilHealth is, I talked about the Universal Healthcare Act. The payer in the Philippines is called PhilHealth, which is the largest payer, and the finance for the PhilHealth has to come from formal subscriptions. For example, I am an employee of Metro Pacific Hospital Holdings. That's my company, which has appointed me. So as part of my monthly salary, a certain percentage is taken and given as a subscription fee to PhilHealth. This is mandatory. I don't have a choice in that. And the company also contributes an equal share. Now, what is interesting is this is a formal engagement, but I have been in Philippines since October, and I have a driver whom I have appointed. That's not a company driver. I have just appointed a Filipino as my driver. But as per law, it's very clear. That's why I find it very interesting, this country, that when I look at labor laws in India and Philippines, like here, it's I have a timesheet. Every month, my driver gives me a timesheet because his 8-hour worksheet is there. So any time he spends beyond 8 hours, I have to pay him overtime on a daily basis. And here we have a 2-day weekend, Saturday and Sunday. If I ask my driver to drive for me on a weekend, I have to pay him extra, which is specified by law. But what I want to tell all of you is the PhilHealth contribution. Even my driver, even though he's privately hired by me, I have to contribute towards his PhilHealth share so that he has a safety net from this. So that is how the Philippine health system works. And it's a very interesting model for providing equity in a democratic society like the Philippines. Of course, providers, I'm not going into details of, but one thing which we will discuss towards the latter part of my presentation is digital. Always we talk about single specialty, multi-specialty, and I remember in some conferences debating actively that will hospitals really be extinct as we know it? This kind of huge capital going into building of hospitals, is it sustainable? Or do you really have to build outpatient departments in hospitals? Because we have so many integrated virtual care apps available. Home care is really big time. Will patients really come to hospitals? Like, this is an interesting question. Of course, I have my own thoughts of it. But there are worries also among healthcare administrators, that especially after COVID, there has been a big a shift in consumer behavior, whether it's e-commerce and also in healthcare space. Will patients really be brave enough to, come into a crowded outpatient, wait for their doctors, and will that interface still take place? Or will digital be the way? So that's something which we can discuss in a bit. And of course, all patients, wherever they are, whether you're in the public sector or private sector, you expect a minimum quality of care. Now let's go into the economic paradigm of the resilience model. What is interesting in the top side is top left side is if you look at, this is the data for household income level projections in India. You can look at 2018, the upper middle income level band, the lower middle income band, and the low income band. So there is a definition of that. When you look at annual income of 8,500 to 40,000 US dollars per annum, that's called the upper middle class. 4,000 to 8,500 US dollars per annum is the low middle income, and less than $4,000 is low income. And of course, very high income, the creamy layer, is above 40,000 income. If you look at the difference between 2018 to 2030, it's quite remarkable that the middle class, the so-called middle class chunk, what we are talking about in India, which is basically for private healthcare, that is the addressable mass, is substantially high. It's quite high. And this also goes in line with the prediction that we have already touched 3 million US dollars GDP in 2022. If not for the pandemic, we would have overtaken France and United Kingdom 2 years back. But that's going to happen next year, 23 and 24. But in the year 2030, our GDP in India is going to touch definitely 8 trillion US dollars, making India the third largest economy in the world. And thereafter, it's just going to go leaps and bounds. I believe, this is my own personal theory, and I keep saying that I hope that the universe allows me to live up to 2050. That's my pet year. If I pop off before that, I would be disappointed. But if I pop off after seeing 2050, I'll be okay. Say, okay, this is a life. Well, why am I saying that? I really believe that because of the demographic dividend, which India is uniquely, what we have compared to China, I really believe that India will be the world's #1 economy in the year 2050 and not China. And that is going to have substantial implications and reverberations, not just for Asia, but for the rest of the world, because I really believe that this is an Asian century, and India will have the pole position in the year 2050. But what I'm trying to tell all of you is that what we have seen is that any country in the world where per capita income level rises up as a proportion to GDP growth, the disposable income expenditure to private healthcare proportionally rises. That is what I want to explain in this graph. In the case of Philippines, I told you the country has 110 million people. If you look at the same slice which I showed about India, what we talked about in the Philippines, because it's a much smaller country, the per capita income level is much higher. At this point of time, it's about $3,700 per citizen in this country. We are talking about 45% of the population is having an annual household income above $40,000 at this time. And what is interesting when you compare India and the Philippines is the percentage of services as a ratio of GDP. Like India actually pioneered the entire services boom because of the tech boom in India, right from the millennium bug in 2000. So the commonality between India and Philippines is the educated, the literate working class. And India is mostly southern states and of course the urban metros, which has really fueled the tech boom in India. In Philippines is a competitor of India, especially in BPO sector. A lot of BPOs from India has migrated to Philippines because this is the only Asian Roman Catholic country, predominantly English speaking. Even though they have 134 dialects, English is spoken widely across the country. So BPO sector is one of the prime engines of growth for bringing in this newfound affluence in the country. And BPO itself is going up the value chain, whether it's to do with animation, gaming, technical services, legal services outsourcing, healthcare services outsourcing. It's all fueling this kind of growth. And that kind of affluence is really causing increased demand for private healthcare in the Philippines. And if you ask me this question, why have I left India to come to Philippines? Because clearly there's an opportunity. I find an opportunity here, and the lessons I learned in India, it can be really applied. Many of the lessons I've learned in India can be really applied for this market. So that's the reason I'm out here. The slide on the bar chart, what you're seeing is median age of Indian population. India is a very young country. So when you look at one parameter in economics, what we need to understand is dependency ratio. India, even when you look at end of this decade in 2030, along with Bangladesh, and I would say even Philippines for that matter, has one of the lowest dependency ratios. Dependency ratio is basically, when you look at numerator and denominator, the amount of young working people in the population as a ratio compared to dependents. Dependents are classified into two. One is the children, less than, let's say, people who are dependent on their parents, and of course above 60. So that is going to change from 2030 onward. So day before yesterday, sometimes I have this habit of listening to the Lok Sabha and Rajya Sabha speeches. I go to YouTube and listen to that. So I was listening to an old YouTube speech made in the Rajya Sabha by Javed Akhtar. All of you know Javed Akhtar, the Bollywood lyricist and I would say an eminent writer. His speech is just very short on YouTube, but what Javed Akhtar was saying is that telling the politicians in the ruling party and the opposition that don't forget one thing: the demographic dividend gives us a window of opportunity of exactly 25 to 30 years. If you miss this opportunity of 30 years, India will become like Japan. What happened to Japan? Because everyone thought that Japan is going to be the next economic superpower, but they just plateaued out. No economic growth much in Japan. If we don't invest in job creating opportunities in India right now, this demographic dividend of young people available, we'll just lose that entire thing. Therefore, we need to create much more opportunity for robust and sustainable economic growth. Now, the other resilience part, when we look at healthcare, is the amount of capital being sucked in, whether it's from private resources or public resources. I can give you first the context in the case of Philippines. From a CAGR point of view, from 2022 all the way to 2030 and beyond, the CAGR is around 9 to 10% of investment, sustained investment in the healthcare infrastructure space, which includes creating capacity, new public beds or private beds, creating the supply chain in terms of human resources. You might be aware already that Philippines is one of the world's largest exporter of nurses to the world, mostly to the United States, to Europe, and also to the Middle East and Southeast Asia. But we are, in spite of that metrics, we still do not have enough workforce for sustaining even domestic requirements. So companies like mine, now the law is different in Philippines and in India. In India, if you're a private company, you cannot really own an educational institution, which has to be under a trust. You know that medical colleges, nursing colleges have to come under trust because that's our act in India. In the Philippines, it's other way around. As the company, as a private for-profit company, I can own educational institutions. So in my network, we have two colleges which are really focused into healthcare ancillary development, whether it's nursing colleges for healthcare technical workforce. It is there already, and we are actually going to, on an M&A sphere, we are planning to acquire more such programs so that we don't face any supply chain bottlenecks because there's a big demand for workers overseas. So overall, the sector consistently attracts capital. You can see that in terms of medical infrastructure, near-term requirement is about 32.16 billion US dollars. And if you look at pharma, biotech, life sciences, it's even much more. So it's quite high. On the right side, when we look at comparisons, I would put, even though the population differences are high, it's kind of eerie that in terms of the bed per 10,000 or the doctor availability per 10,000 population, it's almost similar to that of the Philippines. The education system is a bit different. It's just because of the colonial legacy. India, the Brits were ruling us for 200 years. So our entire medical curriculum is basically of UK origin. In the Philippines, it's mostly following the American tradition. It's basically the board certification and residency training programs in the Philippines. So these are based on the historical context. What this slide I'm trying to highlight is the out-of-pocket expenditure. In India, it's still substantial in spite of Ayushman Bharat being a safety net, which I already talked about. In the case of Philippines, it's as high as 55%. I told you about PhilHealth being there, but please don't misunderstand. PhilHealth does not cover 100% of the total cost of care unless you are in the general ward. General ward is by law. But if you say that, okay, I don't want to be in general ward, I want to be in a semi-private room, or I want to be in a single room, all the extras you have to pay. Either you must have a HMO or an insurance, or you pay out of pocket. And that out of pocket in the Philippine context is as high as 55%. India is also still substantially high. We go into demand supply. You can see for yourself the incredible issue of demand supply gap. We are talking about at the end of this decade. This is for India. We are looking at a gap of almost 1.13 million workers. That number, I mean, friends, just take a minute to digest that. Therefore, in the context of this number, what I said before, it's interesting that when a government in power takes some decisions which I believe will impact positively healthcare. You know, let's just reflect back in the past few years, reformation of the Medical Council of India to what we have right now, the changes in the Indian Nursing Council, the decision to equate on par the National Board of Exams, the DNB programs and the MCI regulated courses to be on par, to really look at district hospitals across India to also become teaching hospitals. And also the earlier for entrepreneurs in India who have the experience of managing private medical colleges, the earlier norms for Medical Council of India, what they talked about infra requirements in terms of land, availability of buildings, it was kind of illogical. I mean, it didn't make much of sense, and that really created a bottleneck. And unfortunately, the existing medical colleges, the amount of wasteful capital which has gone there it's just it's shameful. So a lot of good work has already happened to create and increase the pipeline of healthcare workers in India, but much more needs to be done. So continuing from the same story, the big problem is at the grassroots level. You know, when we look at the real demand and look at the comparisons, when we look at primary care, right? It's just 2.5 health workers per 10,000 population in India where primary healthcare is concerned. Even when we look at the BRICS, you know, the grouping, Brazil, who's our brother country, there's just 4.2. And of course, Mexico is 8.7. United Kingdom, of course, they have the iconic NHS system, which has got a great gatekeeper concept at 12.6. So these countries have really invested substantially in human resources. So we have a big challenge ahead of us. At this stage, when we look at it, primary care, because of this lack of regulatory changes of the insurance regulatory framework in India, IRDA, primary care is still not accessible where health insurance is concerned. We all know our experiences that if we take a group health insurance or an individual health insurance in India, it's mostly for inpatient care and not for outpatient care. So that is a bottleneck. I can give you experiences in a place like Dubai, in United Arab Emirates, where in Dubai it's 100% insurance, where mostly it's private insurance, where there is a clear incentive for facilitating outpatient or ambulatory care services. So there it's much high. So in India currently, private care players are mostly in the secondary and tertiary care space. And you can see the pyramid of existing beds, which as seen in the previous slides is woefully short. Look at this interesting map in terms of United States of India, the differences. I always refer India to the United States of India because it's more of a federation. There's a big gap in availability of beds per 1,000 population based on the individual political will of different states. Now, a bit about demographics. India, yes, is a very young country when we look from a macro point of view. But if you look at our North Indian states, Uttar Pradesh is going for elections next month onwards. The Election Commission of India has already announced that. It's a very young state from a population point of view. India has, it's a slightly modified pyramid, not the classical demographic pyramid, what you see on the left side, what I'm showing of Bihar. And if you look at the state of Kerala, this is an example of what India is going to be overall from 2040 onwards. That's what I talked earlier about the demographic dividend. This has got significant impact on healthcare resilience. For example, what I want to tell all of you is that you all know that Kerala has got one of the best public healthcare systems in the country, mainly because of multi-decade investments in social sectors, education and healthcare. Despite that, you would be surprised to know that 75% of healthcare delivery in the state of Kerala is from the private sector. I mean, imagine that. It's a paradox. Why is that? It's mainly because of the massive impact of non-communicable diseases, because the life expectancy in Kerala is highest in India. The mean life expectancy of the whole population is 75 years plus. And clearly, the longer you live, the incidence of NCDs create that kind of demand for more private healthcare. So this is a clear example where all of us need to look at what are the demographic trends of any space, any part in India or anywhere in the world before we go and build, before you invest private capital going forward. Now, a quick brief about this model, which I find very interesting, both from a healthcare point of view and also from an economic point of view, is that in 1957, the state of Kerala was the first to democratically elect a communist government when Nehru was the prime minister. And from this government onwards, a significant percentage of GDP was allocated for healthcare and education. The net result has been that while per capita income level all the way till 1980s were lesser than other states in India, in HDI parameters, Human Development Index parameters, Kerala was always number one because of investments in social sector, education and healthcare predominating. But what happened after that? Right from early 1970s onwards, because of the Gulf oil boom, there has been a large brain drain. A huge amount of migrants moved away from Kerala to the Gulf states for employment opportunities, where those economies really needed blue-collar workers, much more blue-collar workers to really fuel their economic growth. Earlier than the Gulf boom, you would find Kerala teachers, Kerala nurses migrating to different parts of India, whether it is Bombay, old days Bombay, now Mumbai, Madras, now Chennai, Calcutta, now Kolkata. So there was already an internal migration within India. Now, all these migrant workers, whether they're going overseas or to rest of India, started sending remittances back to Kerala. Now, this had a profound effect in the sense that the percentage share of remittances to the Kerala economy is as high as 25%. And that has created a consumption boom, a consumer boom led GDP growth in the state, plus a knowledge worker related GDP growth, which is predominantly in the services sector. So today, if you look at the GDP pie of the state of Kerala, it is the main contributors are tourism, information technology, biotechnology, R&D centers, space sciences, defense sectors. These are what is fueling the economic boom. And now the per capita income level, that is what the slide is looking at. When you look at large states in India, Kerala has really jumped up there. If you look at earlier, Kerala was not even in the map in 1960 to 61. So what does the Kerala model say? Kerala model says that any state for that matter, if you refer to my earlier statement of the United States of India, if the political class decides that as a strategic necessity for multi-decade growth, if you invest in your people in education and healthcare, the economic dividends are bound to happen. That is what the Kerala model is teaching all of us. A bit of morbidity. We know that because of lifestyle choices, the impact of Zomato and Swiggy. I would also give from personal example that this also is a big contributor to obesity, not just in adults but also in children. Unfortunately, my generation, I belong to the sandwich generation. Sandwich generation is 1965 to 1975 born. Maybe some of you are in a younger age bracket. So we were the generation when we were in school. Like I grew up in Dubai, and I can't remember ever drinking a Coca-Cola. My father never bought me a single bottle of Coke till I was in 12th standard. My first Coke, which I actually drank, was after my 12th standard. And then when I came for college in India, I guess at that time I think Coke was still not available. We had Thumbs Up available in mid 80s. And I did have my share of fizzy drinks and sugary drinks at that point of time. But I'm just trying to say that the lifestyle choices which we all make has got a profound impact on the health of a nation. And that unfortunately is the case of NCD, the big NCD boom, especially diabetic boom in India. We are now number 2 to China. It's just a matter of time when India will have the dubious gold medal of being the diabetic capital of the world. To give you a context, in Philippines, absolutely the same picture. NCDs are a big chunk. The DALY, disease-adjusted life year share in the Philippines is as high as 55%, of which cardiovascular diseases, diabetes, and cancers are very high. The CAGR growth of new incidence of cancers is as high as 65% up to the year 2030, and diabetics is almost 60%. And it is forecasted that by the year 2030, Philippines will have about 6.5 to 7 million diabetics, type 2 adult diabetics, which will make Philippines in the ASEAN region number 2 to Indonesia to be the hotspot for diabetics. So this gives you a perspective of the massive demand for private healthcare just because of lifestyle choices, more affluence, larger middle class per capita income level goes, and hence you have this burden of disease. And this graph is, basically giving you a global picture of what I just mentioned, whether it's cancers, heart diseases, and stroke. And I remember attending a oncology conference in India when I was a CEO of Aster India, where I always had this theory that perhaps it's to do with lifestyle changes and stresses of modern life, which causes cancers. But I remember this onco-epidemiologist making this brilliant presentation. I think he was from the Tata Memorial. What he said is that is not the case. In fact, now we have empirical studies to show that the longer you live, not as an individual, as a society, the incidence of cancers will proportionally rise in a community or a society. And that is the reason why southern states, especially southern states, are finding increased incidence of cancers, because the life expectancy in southern India is proportionally much more than other parts of the country. You can see here the disease burdens when you look at all India data of NCDs, which is the middle segment, it's at 61.8%. You have communicable diseases at 27.5%, and then it's a double bang, double whammy, I would say. Unfortunately, because of our insufficient investment in primary care and also in the public health sphere, We are constantly faced every year during monsoon time. We have these viral epidemics, whether it's dengue, chikungunya, malaria is still a big problem. Tuberculosis in our country has not been wiped out. So we have this double burden of both communicable and non-communicable diseases. Unfortunately, because of rapid urbanization in India, NCDs rule the roost. And you can see the rankings is also changing. Like this is a clear reflection of what private healthcare really needs to focus upon. This is basically an iteration of hospitalization on account of NCDs. You can see the data speaks for itself. Which touched already on key NCDs, whether it's cancers or cardiovascular. And again, to do one spin-off of longer lifespans is the orthopedicians in the group, the musculoskeletal and the physiotherapists in the group. All you guys, especially folks in the orthopedic specialty or rehab facility, you will be extremely busy because that's what happens in a changing demographic environment. The last part is very critical, especially in light of COVID. One data from the National Crime Bureau statistics, which I'm not sure whether you have been exposed to that, is the massive increase in suicides. We all hear the tragic stories of some of the celebrities taking their own lives, especially if they're movie stars. But the hidden tragedy happening across India is, the common man. Many, and it is. I would call this as the suicide pandemic, parallel to the COVID pandemic. So mental health is a much neglected area, and I think lots can be done, and more investments needs to be poured in the area of mental health. This is basically a gap which I talked about earlier in terms of capital magnet of what we all need to do in terms of meeting the WHO and also the Sustainable Millennium Goals, where India has already committed itself to. We have a long way to go, and it can only happen through this focused approach where the state governments increase allocations for social sectors, education, and healthcare. The Niti Aayog ranking of states in India is a classical example. If you look at the latest Niti Aayog report on the index of health ranking, Kerala is clearly the number one. But my take-home message was that, okay, I find that southern states in India are all really up there, where the macro health indicators shown by Niti Aayog is, it's all expected data. And of course, you also expect that Uttar Pradesh, because its sheer size and population and the complexity of the state, is somewhere at the bottom. You would expect Rajasthan has made a lot of good progress. Bihar, interestingly, is one of the most improved states from a broad macro health indicator point of view, especially in terms of female empowerment. But much more needs to be done. But from a private healthcare point of view, the example which I gave you about the Kerala model, in the southern states, in spite of significant investment in the public sector, it has actually created a parallel boom in private. The demand for private quality healthcare has also increased. So what is the lesson for those of you who are students of healthcare? I can give you an example in my own case that when we used to do market research for where should new hospitals be located. So of course, if you want to create a good multi-speciality hospital with a strong oncology department, and let's say oncology, as you know, is capex heavy. If you want to go for accelerators for radiotherapy and also for diagnostics in nuclear medicine, I always say that don't go to a place which does not have a reputed public cancer center. Rather, I would build a good multi-speciality hospital in a city which has got a reputed public, or let's say a trust base like Tata Memorial in Mumbai or in Kolkata. You have that. Why? Because these public institutions act as a magnet to bring in larger volume of patients from the periphery, which they will not be able to cater. So you will have the spillover benefits of sustained volume demand in the private sector. Now, financing models, I talked about briefly before, but what I really want to say is that there are different mechanisms of funding, whether it's tax-based, social. In India, it's completely tax funded. In the case of Philippines, right, there's one more point I wanted to say, that I talked about corporate and individual contributions towards PhilHealth, but something else which is fueling the financing model in PhilHealth in Philippines is Syntax. Syntax is mainly from alcohol and tobacco, which is directly funneled towards provisions of PhilHealth. So This is another lucrative revenue stream for funding expenditure in healthcare. Clearly, where India is concerned, Nirmala Sitharaman, the Union Finance Minister, has walked the talk, and the government has walked the talk of increasing provisions as a percentage to GDP and also direct allocations in the union budget. There are large expectations that the budgetary allocations made in 2021 will continue in 22 also. We all have to wait and see what the union budget is going to talk about. But if you look at an aspiration from an Indian citizen point of view, I really hope that India, at least in this decade, by let's say closer to 2030, has a correlation to substantial increase in GDP growth, what we talked about, $8 trillion US, at least will make a 5% allocation towards healthcare expenditure at the union level. And if the state governments in different parts of India can also increase their share for both education and healthcare, I think that will make a massive difference to us as a country. I'm not going into details of that, but PMJ has been a pioneer of innovation. I'm pretty impressed with the tech platform which they're using for fueling PMJ coverage. Of course, from the private sector point of view, there are a lot of challenges. Folks in the private sector are quite worried about I would say, cohesive policies being used to push private care subscription to Ayushman Bharat. The big challenge is currently the costing methodology used by the regulatory authorities in terms of it is still not scientific, because the theory being that the substantial volumes of cases being given to you will be able to dilute your fixed costs. But the fact of the matter is that the reimbursement rates are much lesser than the central government schemes, whether it is CGHS, ECHS schemes. So it's not really viable for when you look at the traditional overheads of private healthcare. So it continues to be a source of debate, pain point, and challenge. But regulators are going to keep a sharp eye on the cost inflation in private healthcare. So when you talk about resilience model, I think this is something which, as a healthcare administrator, you all need to focus on, that how efficiently can you manage your cost structure to meet a future regulated market, especially in the context of regulators putting caps on your cost elements or your price elements. Just to give you a quick snapshot of, when we look at the healthcare insurance portfolio growth, it's quite interesting that the retail growth has been quite substantial where insurance is concerned in terms of overall outlay. And you know that because of COVID, there has been an accelerated boost towards especially private health insurance. And when you look at this interesting chart out here, you have the PSC insurers, and then you have the standalone healthcare insurers like Star Health, which is already listed. Look at the amount of business which Star Health has earned. If you look at Max Bupa, Care Insurance, they are all growing in multiple, compounded growth, which really shows that as an administrator, if you have the unfortunate luck to be a hospital CEO, you will be faced with all these kind of tailwinds. I've already explained all the headwinds, which are the factors why you ought to be in healthcare, but we have to be realistic also that these tailwinds are there, and we need to figure out that how do we have a win-win model where they don't squeeze you so much that you go into bankruptcy. The last frontier is basically digital. If you look at the profound changes all around us that I've already talked before, that the new, in the context of the traditional provider base and the debate whether hospitals need to have large outpatient departments, that this aspect of integrating home care and virtual care services growing phenomenally, whether it's been a lot of private equity investment is going towards this. Existing players, hospital chains are investing in that. You have all your Fitbits keeping track of what you eat, how many steps you have done, your exercises, yoga, sleep cycles, all that is being monitored. And of course, your traditional, our brick and mortar hospitals, the amount of IT investment you need to make it to ensure that it's up to date. And of course, financing, a lot of financial reforms coming in. Like, for example, if you look at e-commerce space, I was just reading an article yesterday about the silent revolution among the e-commerce players in India, whether it's Flipkart or Amazon, where the national distributors, all of them are up in arms because they're getting cut out from the supply chain. The new e-commerce players, which have got deeper pockets, like they don't have an operating profit model, but I suppose their mantra is on valuations. And hence they're able to give such deep discounts to the end consumer, whether it's a Aam Aadmi or a Kirana shop, where your traditional retail, your traditional distributor is not able to match those sort of discounts, and they're getting wiped out. So there is a pushback from that. So in healthcare, similar kind of innovations are taking place, where you have standalone startups in the fintech space, which would go into subprime lending, for example, or earlier patients who had challenges of accessing private healthcare because of affordability factor. Now you will have access because they have a different algorithm of calculating their credit worthiness. So a lot of innovations are taking place. And also, when you look at support services, like somebody like me, I'm based in Manila, and I have elderly parents. My mom and dad, they're senior citizens based in Trivandrum. Now they have their healthcare challenges. Now, how am I able to manage the ecosystem and support system from Manila to Trivandrum? So this is purely, and I'm really grateful that we have the technology platforms available, whether it's home care services, Fitbits for real-time monitoring of health status, support from a brick and mortar hospital setup in Trivandrum, and of course, in terms of net banking and the healthcare apps available. That kind of an ecosystem creates a social support for the growing geriatric base in our own country. I'm just sharing a personal examples for all of you. And of course, the key drivers in terms of growth is there is cost pressure on traditional models of healthcare. We have to think out of the box because there is, as I've already mentioned before, the demand exceeds supply. And this is the case we are seeing all over the world, especially in Asia. But at the same time, not like the old days, that even though demand exceeds supply, the price point has to be based on a certain value proposition, where you have media in democratic societies. Media play a key role, and also regulators play a key role. Like to give you an example, in terms of China has gone hammer and tongs against tech firms. And for example, in the education space, right, all the Chinese tech firms in e-education, they have all been hammered out, mainly because the Chinese regulators have realized they keep monitoring the social media postings, right, and the kind of distress, economic distress, which families in China have faced because they're basically victims of marketing. And same thing in India, where I know the parliamentary committees are already discussing of players such as Byju's, for example, in India, this entire e-education model. So what I'm trying to say is that there will be increased scrutiny on cost structures for all of us, and we need to be aware of it and still be resilient. Consumers, of course, always look for heightened demand of transparency. To give you an example, in the Clinical Establishment Act, which many assemblies in states across India have already passed, one of the key aspects of the Clinical Establishment Act is hospitals have to publish their rate card where patients can really see. In the Philippines, for example, similarly, the Department of Health, which is the regulator, they have demanded that if you want, every year you have to renew your license to operate the hospital. Now they are using that as a stick to beat private players, that if you want your license to be renewed, you have to give all your prices to them. So at this point of time, I can tell you that the Department of Health in Philippines has got the price points of all hospitals in the Philippines. And I'm quite sure that they are going to use that to negotiate or to put in some kind of price caps to ensure that there is some degree of cap in the cost inflation in this country. So this is something which all of us need to be aware of. Of course, the whole aspect of nearshoring. Nearshoring is this philosophy. Earlier, we used to talk about outsourcing models, especially now in this heightened awareness of your personal health data. Nearshoring is the term where you need to have, like in India's case, we insist that all the data clusters have to be located within the borders of India. You cannot really outsource data, and hence we are sure that from a regulatory framework, at least all the healthcare data sits within the Union of India. where our national borders are, where we have sovereign control. Same status with Philippines, and more countries are really going into that. So the next step is that we have to look at, we can't afford to be in silos like the old maxim goes, but we need to look at from a sectoral point of view. Industry players need to get together, not just as providers. You need to collaborate actively with the insurance payers, with the medtech industry, with fintech industry, with manufacturers, with pharma. Everyone has to be together, because ultimately, from a patient point of view, collectively you make a big difference to them. So this is what is really changing. COVID has really shown us, specifically in India, that it is not the chief information officer of any hospital which has really accelerated digital transformation, but it's basically the pandemic. Whether it's in terms of adoption of by doctors of teleconsult platform, by the consumers, we talked about it because of the lockdown in 2020. It led to a rapid delta in consumption of healthcare. So this is here to say, but the big question is the whole telemedicine market models, right, on revenue assumption. What happens if, let's say, Omicron, like that's the theory what I have, that this Omicron wave is like a tsunami, all of us will get infected. We will all build a natural immunity, because I think Omicron is like a natural vaccine. And by summer this year, 2022, that's it. Then the COVID-19 becomes an endemic. No more pandemic. So I'm curious to know that Q3, Q4, what will be the consumer behavior for all our hospitals? So that's something which we have to see. Basically, what this reflects on what I mentioned before, that there's a massive economic churn going on in the digital space, in terms of consumer demand, regulator interest in this area, and of course the sustained interest of enterprises. Like, for example, if you look at Apple's collective market cap is, I think, is $4 trillion US. Is much more than India's GDP right now. But if you look within Apple, the amount of investment which they have made for the healthcare vertical, it's incredible. Same thing what Alphabet is doing, and also others. So we are living in exciting times, and yes, all of us are going to be impacted because of these changes taking place. If you look at this top slides, I think emerging markets in Asia are really benefiting from this new paradigm, mainly accelerated due to COVID, and also the acceptance of the consumers to go into e-platforms, like whether it's, of course, started with e-commerce, and easy availability also into e-health platforms. So when you look at an integrated healthcare app, you're looking at a consumer sitting in the comfort of his home, who can have on-demand appointment with doctors, appointment scheduling, let's say e-consults. The doctor has an episodic encounter virtually, orders for certain drugs, which is delivered through the e-pharmacy channel, orders certain medicines, which a combination of e-home, home care, and also e-diagnostics, that takes care of that. So a big chunk of chronic disease management really can be in a retail format, need not come to a hospital. So that's what we are seeing increasingly in emerging market models. That's my last slide. So in summary, what I feel is going to happen is that there will be a degree of health equity, especially in Asia. Despite our current challenges, more or less there will be an equity in terms of the pyramid of AAA. That's what I see happening. And of course, there will be increased community engagement, whether it's to do with our patients, our doctors, regulators, healthcare worker, the voice of the healthcare workers. I think it's going to be different, like your own class, because I saw the percentage of doctors in this class. The fact that many doctors are now investing in their business management education, I think it's a wonderful thing. Knowledge is power, and I'm all for for all of you to get much more deeply engaged in the healthcare sector. Yeah. So I guess that's my presentation. Thank you so much.